It is really my pleasure to start our scientific sessions and to introduce our first speaker, Dr. Smita Prasad. Smita is an assistant professor of addiction medicine in the Department of Psychiatry and Behavioral Sciences here in New Orleans at Tulane School of Medicine. Please join me in welcoming Dr. Prasad as she presents on balancing pain relief and addiction risk, clinical insights from addiction medicine. Smita, it's all yours, and thank you and welcome to the SMA.
Yeah, thank you. Woo. I'm honored to be your inaugural speaker for the conference. And since there's such a small group, please feel free to, I guess, raise your hand or raise a box if you have any questions. But yes, my name is Smita Prasad. I moved down to Louisiana in 2013 to do my family medicine residency and went out and practiced family medicine for a couple years. I got a locums job and I picked it up as like litigation medicine, and I was prescribing a lot of opioids and muscle relaxers and benzodiazepines, and I got locked in with a contract. So I stayed there, started drug testing people, and that just kind of piqued my interest in addiction medicine. And that's why I was the second fellow at Tulane to go through the program and have stayed on ever since. I wanted to be part of the solution, not part of the problem. I have no disclosures. Okay. So, balancing pain relief and mitigating addiction risk it's difficult. It does require a patient-centered, multidisciplinary approach that prioritizes non-opioid therapies, careful opioid prescribing, and ongoing risk mitigation. I think that's probably different than what you all were told 20 years ago, when opioids were much more freely flowing. What we know is the intersection of pain and addiction is complex. It's overlapping with these biological, psychological, and social factors. And it's further complicated by health disparities, stigma, especially among marginalized populations. Safe pain management begins with an individualized biopsychosocial assessment and shared decision-making, and so does a treatment for substance use disorder or an addictive disorder. Individualized biopsychosocial treatment. Opioid therapy, I think everybody knows this by now, should be reserved for refractory pain when all other modalities fail, and really only when benefits outweigh the risks. And just, to be careful with special populations, such as those that have an active or past opioid use disorder. You might want to approach these individuals differently. Oftentimes, I have patients that are in recovery, we'll just say no narcotics if they have to go see a doctor or a dentist for a procedure. So managing pain, these are the principles. It's really important to establish a clear goal and focusing on the person's function. I never tell people that I could get their pain down to 0 from 10, because that's really unrealistic, and it kind of sets them up for failure. So we set reasonable expectations, especially when it comes to alleviating the pain, and use a multimodal approach to meet treatment goals. And I was the medical director for many years of a residential treatment facility, and a lot of these components are also used in substance use disorder treatment. We had a wellness instructor who did yoga and she's actually going to come next week and talk to my fellows. We brought in a massage therapist to help treat our patients, and CBT obviously is very prevalent, and we provided oral and topical analgesics that were not opioids, and provided healthy activities and diet. Good sleep hygiene is very important to people with recovering from substance use disorders. The interventions, these are, I guess, kind of things of last resort, but can be done in conjunction, like joint epidural steroid injections or trigger point injections. Sometimes they're definitely better than an opioid. So pain is complex. It has many faces. There's emotional pain and suffering. There's physical pain. There's neuropathic pain. And this is the three main categories of pain. Nociceptive pain, which is pain related to the damage of somatic or visceral tissue due to trauma or inflammation. Neuropathic pain, pain related to damage of peripheral or central nerves. And I do see this a lot in patients that have older patients with a severe alcohol use disorder. Sometimes they can get neuropathic pain from their heavy drinking. And the last is the sensory hypersensitivity category, pain without identifiable nerve or tissue damage thought to result from persistent neuronal dysregulation. So this is like your fibromyalgia, irritable bowel syndromes, interstitial cystitis, restless leg syndromes, and they can be very difficult to treat. And of course, the ways that pain is described are different. Someone experiencing nociceptive pain might complain that their pain is sore, throbbing, dull, aching, cramping, whereas someone presenting with neuropathic pain might complain of it being hot, burning, tingling, numbness, pins and needles. And someone with the sensory hypersensitivity or nociplastic pain, those symptoms vary often, but fatigue, non-restorative sleep, so these are more like this mood disturbance, not the like hardware type of things that are being disturbed here, and sensitivity to sensory input such as bright lights, loud noises, and smells. So we're going to classify pain in two types, acute and chronic. And this is how I approach pain when I treat pain. Is it acute or is it a chronic? And if it's acute, it's going to be like more like the functional pain. It's like an alarm system in the body going off saying, oh, been in an accident and I don't know, my leg's been severed off, like that kind of pain. Excuse me. Yeah, but it's pain, but it's time limited. So you're going to get the surgery, you're going to get it corrected, and it'll resolve. And this pain is usually related to tissue damage, hardware, or surgical scar, maybe. An infection might cause this type of pain, or a fracture. Whereas chronic pain is like nagging, not functional. It's just there, irritating, persistent, unending, and it's related to the nervous system, which is like the software in the body. So again, think of your fibromyalgia, irritable bowel syndrome, complex pain regional syndrome, those type of pains. So what to know about acute pain? My patients, I guess all patients, they really do fear being mistreated and not having their pain adequately treated because maybe they have a history of substance use disorder. Whereas, excuse me, like as a physician, we kind of get we fear being lied to about their pain, being deceived. We like assume maybe they're drug seeking when really they're just in pain and they need better pain control. So it's really important to coordinate with other practitioners. Um, if the person has an opioid use disorder and is on a maintenance drug like buprenorphine, you're going to continue that. And you can maybe divide the dose for analgesia acutely. Or, you might need to use higher dosing of short-acting opioids, depending on where you're seeing the patient and what type of physician you are taking care of them. Might want to consider using high affinity agents like hydromorphone, and consider scheduled PO dosing versus IV PRN. If you give somebody that PCA pump and they have a history of opioid use disorder, they're going to just drain that pump boop, 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 real fast. Oh, sorry. Got better. Okay. Well, okay. So managing acute pain, just reassure the patient that it is self-limiting. My patients that are in early sobriety have a very low distress tolerance. So if they stub their toe outside, it can be the end of the world. But pain is self-limiting. And again, using a multimodal approach to treat the pain, NSAIDs or acetaminophen, non-drug approaches like massage, wrapping the injury, but want to do multiple things with the goal of improving function, reducing suffering, and minimizing treatment-related risk. So optimize treatment options with the best safety profile and reduce risk if you do prescribe an opioid. If you're in the ER and you have someone that comes in with something real painful and you got to send them out, maybe just prescribe a short course of the medicine, lowest dose and smallest quantity. Avoid co-prescribing with benzodiazepines, which I could go on a rant about for more than an hour and a half. But yeah, you don't obviously want to make them high risk or increase their risk, excuse me, for respiratory depression. Use immediate release opioids and continue to optimize those non-opioid treatments. And just be, yeah. Oh, better? All right. And definitely exercise caution if you're going to prescribe an opioid for greater than 30 days, because this is likely they're going to develop physiologic dependence and it become long-term treatment. And when I picked up this practice out of residency, he was a neurologist that had a heart attack, and he was taking, like, lawyers were sending their clients to him, and he's evaluating them for back pain, neck pain from their injuries. Yeah, it was every month they were coming in, and he was giving them the same amounts of opioids over and over and over again. So it's very interesting. Don't do that. Okay, key points about chronic pain. Again, all pain is real. Just because someone has the disease of addiction, doesn't mean that they deserve to be in pain. It just might mean we have to get a little creative in the way that we treat it. All pain is real. Thoughts and emotions drive the experience of chronic pain. Happier people, like people that are exercising, they're gonna not experience chronic pain the same way as someone that is sedentary and maybe depressed. So think positively. Opioids often make pain worse. Opioid hyperalgesia. Goal, treat to improve function, and just know that your expectations do influence outcomes. Okay, so this is some evidence-based treatment for, there's 4 conditions. They looked at osteoarthritis, low back pain, diabetic neuropathy, and fibromyalgia. And these are like all the evidence-based treatments based on all of the research that they did. And you want to choose evidence-based treatments for chronic pain, whenever possible. And if you notice, for all 4 of those conditions, osteoarthritis, low back pain, diabetic neuropathy, fibromyalgia, other opioids, besides buprenorphine and tramadol. I'm also not a fan of tramadol, but we'll get to that. Basically everything else, or those are red, the other opioids are red, and everything else is green. Means yes, you should do that, like exercise, physical therapy, Tai Chi for osteoarthritis, or yellow, maybe the TENS unit for diabetic neuropathy. You can use it, but there's not a lot of evidence behind it. But I just thought this was interesting. Also, I try to kill a lot of birds, multiple birds with a few amount of stones. So if I have a patient that has comorbid pain and like numbness and tingling, and they have sleep problems, well, I might try them with the tricyclic TCA. I'm sorry.
Oh, I was just curious. With the tramadol, you mentioned you're not a fan. Is it efficacy, side effects, drug interactions, or abuse, or something else?
Yeah, abuse. Basically.
Abuse of tramadol?
Yeah, I've had quite a few patients that have abused it, so it does have abuse potential. And I will really, I'm very conservative. I'll take you off, and maybe my patients don't like me for this, but if you come into my residential treatment facility, no stimulants, the only opioid I will allow is buprenorphine. That's because it's a partial agonist. Certain muscle relaxers, like there are case reports of Flexeril, people having overdose on Flexeril, so I don't allow Flexeril, but
Totally agree with you on that. Chris?
FDA just approved a sublingual cyclobenzaprine for fibromyalgia.
oh,
So Flexeril maybe take a second to look at that.
Well,
It's true.
oh, I know, but approval versus wanting it could be different things. Do you think that the way in which tramadol was initially advertised made it easier to prescribe and probably led to some abuse by, I know it was pitched to us as not an opioid.
I remember it being on the Walmart $4 script list because my dog was on tramadol, and they use tramadol a lot in veterinary medicine. It was, I guess like all opioids, they're not addictive. It was in the 80s. I think there's a Jick and Porter something. So one little editorial in the New England Journal of Medicine that everybody quoted because it said, I don't know, like opioids don't cause
Taken as prescription.
addiction.
Addiction.
Yeah,
Yeah,
and
tough.
well, they were wrong about that one.
Any other question?
So
Okay.
again, treating chronic pain, we want to maximize your pharmacologic non-opioid options, NSAIDs, and I get a lot of patients that are allergic to ibuprofen and Tylenol and everything that is not an opioid, but it is what it is. So NSAIDs are helpful. Tricyclics and SNRIs can be helpful. I use a lot of amitriptyline, again, for if they have neuropathy and headache and are having problems with sleeping. SNRIs are also helpful here. Anticonvulsants use a lot of gabapentin, which I think some of my colleagues are reevaluating the amount of gabapentin that we're using in addiction treatment because it's been implicated in so many overdose deaths. Like there was a JAMA 2020, maybe there, but so like something like 80% of opioid overdose deaths, they found gabapentin in them. So, or excuse me, was one of the components. So, but I still use a lot of gabapentin, but kind of rethinking that.
So do you have a maximum dose though that you use your gabapentin at? Because I know a lot of those were real high level, higher than absorbable level.
Yeah, I mean, I think that the highest therapeutic dose is supposed to be like 3,600 milligrams. I had a patient who was being treated by a neurologist after a motor vehicle accident. He was prescribing her 6,400 milligrams of gabapentin a day. And then when he decided to go to another practice or retire, he transitioned her care to someone else. And no one, this was a couple of years ago, no one would prescribe her that much gabapentin. And I mean, if you don't, he gets a pretty severe withdrawal from that gabapentin. So,
So do you use much pregabalin as well when you get into higher levels and are looking for a better affinity or better absorbability?
I don't, but I don't take people off their pregabalin if they come in on pregabalin. And that's kind of like with that risk benefit situation. But I don't use a whole lot of Lyrica. But I do, and I definitely don't prescribe benzos or soma. I've had I get lots of people that are dependent on the benzodiazepines, and for many years, I didn't see primary benzodiazepine like use disorders, very rarely. And now sometimes I'm getting older individuals who were getting 20 to prescribe 20 to 30 milligrams of diazepam 20 to 30 years ago, or still getting it from their psychiatrist or internist or whoever, excuse me, and then now no one wants to give them their diazepam anymore. And so I've had to help them get off of their benzodiazepines, which is really difficult to do. Can take years, and I've not had a whole lot of success with it. But that is also another story, but benzos are bad to me. But I use a lot of topicals, like diclofenac gel is wonderful. We will allow that, Bengay, and then low dose naltrexone. Does anybody use low dose naltrexone for pain?
It's Vivitrol, but not for pain.
Wow. Yeah. So I think we're going to talk about it. You have to get this compounded 5 milligrams per day. Okay. So there was a large trial back in 2018, the SPACE trial, and it was the first large-scale, year-long randomized controlled trial that compared opioid and non-opioid approaches for treating chronic pain. And so this kind of shows the steps. So the step one, they compared opioid, morphine, oxycodone, and then hydrocodone with Tylenol to non-opioid acetaminophen or NSAIDs. And then in step two, like 2 morphines or oxycodone was compared to nortriptyline, gabapentin, capsaicin, lidocaine, and amitriptyline. And then step 3 compared the fentanyl patch to pregabalin, duloxetine, and tramadol. And this is what they found. with an N of 240 veterans, take care of a lot of veterans with moderate to severe chronic pain. They found that the pain-related function didn't really differ all that much between groups. And pain intensity scores were decreased in the non-opioid group compared to the opioid group. Patients randomized to the opioid group and they had more medication-related adverse effects. And they found that NSAIDs work as well or better than opioids for low back pain or osteoarthritis. Now, you try to tell one of my veteran patients with a comorbid opioid use disorder that they're not going to say that they're sufficient for their pain, but that's what they found. Okay, so low dose naltrexone. This was new to me, and I've used it several times over the years when they don't want, we're not using buprenorphine, but it's shown some promise in reducing symptoms that's related to chronic pain conditions, fibromyalgia, irritable bowel conditions, and multiple sclerosis. So those nociceptive type pains. The mechanism of actions appeared to be that it modulates neuroinflammation, the modulation of glial cells in the brain, and the release of inflammatory chemicals in the CNS. That's what they think. So there was a study, a small study, but they found 6 out of 10 participants with fibromyalgia reported a greater than 30% reduction in symptom severity when they took low dose naltrexone in the middle part. So, I mean, I think for some people that I treat, this is an option. Maybe not the best option, but it is an option for a certain patient. So why are opioids bad? Well, we know they have side effects, GI side effects, constipation being the main one there. They can cause persistent itching, cognitive effects, endocrine and immunological issues occur with chronic opioids. I get a lot of guys that want me to check their testosterone because in treatment, they've been using opioids for a long time. And I mean, originally my mentor, he was like, yeah, we can add that to the admission labs. But then we started checking everybody's testosterone levels and it got to be a mess because then everybody wanted their testosterone repleted. And so now I don't check it and I tell them they have to go back to their PCP. But I have a lot of patients that were on chronic opioids that are getting testosterone repleted from their primary care doctor. And we know it can cause immunologic issues too. They can cause tolerance and physical dependence. And this concept, addiction versus pseudo addiction. Just like where I don't actually understand it completely, but I guess it's more like you're dependent, but not like you don't have to take it. I don't know, weird. I don't understand. Sorry. But loss of function is a problem, and you can perceive emotional pain as physical pain, like using opioids for chemical copers. I do have patients that like, oh, I had a lot of anxiety and took a pain pill and that helped their nerves. Hyperalgesia is a concern too. And then diversion. Obviously, we all fear diversion and the DEA coming in and to our offices. So if you're going to have to prescribe opioids for chronic pain, definitely weigh your risks and benefits. And as you can see, there are way more risks than there are benefits. But benefits include reduced pain more than placebo in short-term studies. Overall, though, prescription opioid prescribing is decreasing in both of my states. Kentucky, where I'm from, and here in Louisiana, we were still really bad about prescribing opioids. Primary care doctors for opioids. And if you have Netflix and you haven't seen The Pharmacist, I highly encourage you to watch that documentary. It's about a pediatrician who decided she was going to start treating pain in New Orleans. And it just became this huge industry. I mean, this was like 20, 30 years ago. And she'd have like lines out the door for people because she wasn't doing physical exams, I guess, and she's treating adults with pain. And then she'd have to get bodyguards and I don't know, because you're doing it all hours of the day, but it's very crazy. So you should watch it. But anyway, overall, we're doing a little bit better here. So if you're going to prescribe an opioid, maybe it's helpful to know what your options are. And we classify them based on how they bind to the mu opioid receptor, which is also the morphine receptor. If it's an agonist, it's going to create morphine-like effects. So heroin, which I rarely see anymore, fentanyl analogs, those are going to create morphine-like effects, euphoria, and they're going to stimulate at least one of these three opioid receptors here, and they're going to continue analgesia with continued increasing of the dose. Whereas a partial agonist like buprenorphine, it's going to create weak morphine-like effects. So it has a high affinity and low dissociation from the mu opioid receptor, which is great. So you get the ceiling effect on respiration and CNS depression. So it's very safe, but we don't know like how much it can help with pain, and the ceiling effect is unclear. But it's still the only tool that I have, not the only tool, but the biggest tool. Well, I have because methadone you have to get from a federally qualified OTP. Methadone being an agonist, so I am not involved with the OTP. So buprenorphine it is my go-to. And then, or is it an opioid blocker like Vivitrol, naltrexone, where you get no effect in the absence of an opioid or an opioid dependence. And here you're going to get competitive binding with agonists. And they don't have an analgesic effect except for low dose naltrexone that works on these glial cells, microglial cells. Here just showing the activity at the morphine opioid receptor. A full agonist, you're going to get full receptor response and full effect. Whereas with that partial agonist, buprenorphine, you don't get as strong effect. And then naltrexone, the antagonist, you get no effect there. So buprenorphine for the chronic treatment of pain, yes, or pain, chronic pain treatment. It's really my favorite tool and one of the only ones that I have. It is available as an injectable IV. It's called Buprenex. I've never seen it, but I don't know, our hospital doesn't have it on formulary, but I have heard that it is available. They have buccal strips and transdermal patches. So these are FDA approved for pain treatment. They're effective, very effective. They can be used long term. and they produce pain relief that's similar to other opioids. And they're associated with fewer side effects. So here you can see the percent change the percent reduction, excuse me, in additional opioid analgesics for breakthrough pain. If they were on a stable dose of buprenorphine, they would use less of the oral. And I'll just highlight this, and I think I say it, but the dosing is different for when you're treating it when you're using for pain. At least for the Belbuca and the Butrans patch, these are micrograms of buprenorphine. Whereas for fentanyl use disorder, I am using 24 to 32 milligrams of buprenorphine. So it's definitely different dosing. And we'll talk about buprenorphine as MOUD. Again, it's the only tool I can prescribe besides Vivitrol. I don't find Vivitrol very helpful with fentanyl use disorder. This certain population. So, but buprenorphine, it's a prescription drug. It's illegal. You don't have to have that X waiver anymore. There's no caps. It's like 30, 100. You don't have to keep track of all that. You don't have to offer therapy to be able to prescribe. And it comes in many formulations. Now it's generic. There's buprenorphine with the deterrent naloxone or buprenorphine by itself. And I have most of my patients think that it's the naloxone component that causes those rapids, precipitates the withdrawal. They don't understand it's actually the buprenorphine itself being a partial agonist and partial blocker. But so I've just gotten to the point, whatever, if you're going to take it, whatever you want. We'll give you buprenorphine. Or sometimes they'll say the naloxone part gives them a headache. It comes in sublingual films, sublingual tablets. I do like to do what I call macrodosing of my patients that were heavy fentanyl users. I macrodose them onto buprenorphine, and the tablets do dissolve faster, so we really hit them hard, and they're always scared because they've gone through rapids before. It's really incredible how well people can do with this. It's not an evidence-based protocol. I just came up with it based on what my mentor had told me. And I give 8 milligrams of buprenorphine every 15 minutes for 3 doses. And then I do an optional 4th dose after 30 minutes. And if like the withdrawal hasn't fully reversed, and I swear people do really well, really, really well. That's awesome. I've gotten people off of methadone using that, and which is difficult to do. Okay, but buprenorphine and naloxone, the buccal also comes in a buccal film. A lot of people get those films. Not the buccal film, excuse me, they get the sublingual films. But these extended release injections are amazing. Now we have Brixadi, which they comes out in weekly and monthly dosing, and they have different dosing. So they're just really a helpful tool because some people everybody needs different. But Sublocade is probably my go-to. Sublocade is a long-acting buprenorphine product, and I use I prefer to use Sublocade to get my patients off of buprenorphine. Like I've had lots of people that have been taking the films for 14 years and they have great jobs and they got kids and everything's going super well and they don't want to take it anymore, but it's really hard to get off of the sublingual. But Sublocade makes it very easy, minimizes the detox symptoms, and definitely my go-to when I'd have to do that. But yeah, so as MOUD, it's great. I also find anecdotally Sublocade is better, stronger in the setting of opioid use disorder, fentanyl use disorder. And I will give buprenorphine sublingual on top of the shot. I'm very liberal with buprenorphine prescribing. And I'm probably one of a few people in the state that will do that, but takes what it takes. So the opioid partial agonist, it's designed to diminish the effects, again, of physical dependency to opioids, increases safety in cases of overdose, and lowers the potential for misuse. I can prescribe it in my clinic, and I do. Many places, you don't have to, again, be a licensed methadone clinic like an OTP. It's used to treat withdrawal, cravings, and overdose. It's safe and effective for treating opioid use disorder. It's got a high affinity, it's long acting, and about 24 to 36 hours. But side effects, again, kind of similar to full agonists, sedation, constipation, decreased libido, and can cause headache. Should not be mixed with sedatives like benzodiazepines and alcohol. And should be started when the person is in mild to moderate withdrawal to avoid precipitating withdrawal. Except if you're going to do that macrodosing like I do, precipitate the withdrawal and then quickly reverse it. And duration of therapy for the patients, it depends on what their treatment goals are. And that's something I've learned over the years is that everybody's recovery looks different and their treatment goals are different. Some people want to be California sober and you just use cannabis, okay. But they don't want to do opioids like fentanyl anymore. And I have to support that. I guess it's harm reduction. So discontinuation of therapy should occur with support of the treating physician. And this is just kind of showing how buprenorphine stabilizes the opioid receptor. I like it because it's easy for me to visualize it, but if the green balls with the spikes, that's your full opioid, full agonist, and you got the buprenorphine, the little balls, then the full agonist will sit in that opioid receptor very nicely and give you euphoria and treat your pain. But those little balls of buprenorphine, if you have buprenorphine, will come in and sit on top of the receptor and kind of just block those full agonists. So, and buprenorphine will block opioids as they dissipate. So, they can protect somebody from overdose death for 72 hours. And I think that's just fantastic. Again, so we know buprenorphine reduces overdose risk. This is in Baltimore. They found that heroin overdose deaths fell by 2/3 as buprenorphine availability increased. So red is the heroin overdoses and the checkered bottom line, that's the buprenorphine. And methadone is a great tool too. I just can't prescribe it. And I've been working with some of my colleagues in the area about starting it they want to start it in the hospital and then transition that person to an OTP if they have opioid use disorder. And so for some people, this is the way to go because it is a potent full agonist. It has unique properties though. It also acts as an NMDA receptor antagonist. It's effective for treating both nociceptive and neuropathic pain, useful in opioid hyperalgesia, or when pain is unrelieved by other opioids. The problem that uh, I've seen in the area, another colleague was also agreeing with this. We will get people like that come in on methadone, we'll get them on to buprenorphine, like in the hospital setting, and then they will go somewhere else and they will get switched back to methadone to treat their pain. And you know, there's, I guess, lots of issues around here, and us not working together. But we are trying to get better. Anyway, so methadone indicated for persistent, moderate to severe chronic pain requiring continuous treatment. This could be like cancer-related pain, neuropathic pain, patients with renal impairment. The dosing and titration requires caution. This is why these people, if they're going to the OTP, they have to come in fairly regularly when they're getting initiated. It has a long and variable half-life, 15 to 120 hours, but we know that the analgesic duration is much shorter, and methadone dosing traditionally is once a day. So if you're going to use it for pain in the hospital setting, you can give it for divide the doses, which can be really helpful. But the analgesia can last from 8 to 12 hours initially, then it can extend to 8 to 12 hours with repeated dosing, or 4 to 8, excuse me. Initial dosing for an opioid naive patient is typically 2.5 milligrams 3 times a day, whereas I have colleagues in New England and other states that are using, like, I've heard of really 150 to 180 milligrams of methadone for opioid use disorder. I've had one person, she said she had to go up to 300 milligrams of methadone. So again, it's just different dosing. And you can titrate this every 5 to 7 days to avoid it accumulating in toxicity. But you do have to be concerned about QTC prolongation. It can increase a person's risk for torsades de pointe. They recommend baseline and follow-up EKGs. But when I asked around, there are not any OTPs that are doing baseline EKGs, but they can sometimes it will send people to, I guess, their PCP or clinic urgent care to get EKG if they're concerned. But with methadone, you got to be concerned for drug interactions. There's lots of side effects too, constipation, sedation. They can cause nausea, and we may require input from a specialist to be able to prescribe it properly due to its pharmacokinetics and safety profile. But methadone is very inexpensive and it's available in many formulations. And for a certain person, it might be very effective for treating both chronic pain and opioid use disorder. So there's plenty of evidence that show randomized controlled trials that show superior analgesia and comparable side effect profiles to other opioids. And I, for a long time as an addictionologist, kind of just forgot about methadone, but trying to bring it back. Okay, so the purpose of MOUD, especially methadone maintenance, it's to block the withdrawal symptoms and craving by occupying those opioid receptors. So it's not replacing one addiction with another addiction. It's just helping the person focus on something different. It replaces the agonist, heroin or fentanyl in the body. It's like, I feel like it gets long-term storage in the body. And once you get this maintenance steady state is achieved, it's, the patient's not going to be going through the ups and downs of like with sublingual dosing of buprenorphine, they treat themselves and they start to feel their symptoms will stabilize. And then as it wears off, then they start to go through withdrawal. They don't deal with any of that. It just goes stable. And the physiologic steady state creates this physical dependence, but it helps stabilize neuronal changes to avoid intoxication and withdrawal. And it leaves the body very, very slowly because it is long acting. And we know it works. It was designed to prevent individuals from experiencing craving for opioids, being so preoccupied with opioids, compulsive drug seeking and using, salience of the use, and impaired control over use. And it's designed to help with multiple life problems, crime, employment, family health, mental health, help people get those stable and all the things in recovery that are really helpful. GLP-1 agonists, there's a lot of ongoing research about those doing very similar things. They reduce the urges and cravings for sugar. And my husband's on semaglutide and he says it just turns the food noise off for him. So, and we're looking into those for an alcohol use disorder. Anecdotally, I've had patients that have told me their Manjaro helped them with decrease their alcohol cravings. And so I will not take a person off of their GLP-1 agonist. And if they have the indication of obesity or they have the proper indication for it, in addition to their use disorder, I've even prescribed it. Just whatever helps. So, okay, if you want to initiate MOUD for analgesia in the hospital, so you've got somebody that's in pain, they have that history of opioid use disorder, you want to put them on buprenorphine. There are several ways to do it, but just note for methadone, which is that first column with the star, this is a multi-day process to get somebody on a stable dose of methadone that would be helpful for their opioid use disorder. And then you have to have the social worker help find them an OTP, and then you have to get them to the OTP the next day. And I don't know, I just highlighted that because most insurance companies, right, are trying to push people out the door as soon as they get to a hospital. So if you're crunched for time, you might want to consider buprenorphine for pain and MOUD. But then the problem becomes I guess, at least here in New Orleans, nobody in other specialties like the ER, they don't want to prescribe anything longer than 3 days, or they don't feel comfortable prescribing anything more than 3 days. And so patients return to use. If they're leaving the hospital with only a 3-day supply, you can't really get into very many places very quickly. So give them enough if you are so kind. Okay, so again, this standard dosing protocol to treat fentanyl is evolving and varies greatly. Lots of evidence now is emerging that shows we can use higher initial doses. Initially, and I think it was like you start off at 30 milligrams, then you have to come back the next day at 5 in the morning, and then just to get titrated. But now they're trying more rapid titration than traditional protocols, trying to get people to a safe dose, therapeutic dose faster. And just being more aggressive, really being more aggressive, treating opioid use disorder. And I think it's helping. I mean, last year, right, our opioid overdose deaths were down, so which is good. But you can expect now in the setting of fentanyl with these synthetic analogs, if you have a patient on methadone, they're probably going to be on a dose that's greater than 100 milligrams. And it's hard because I don't think on the PMPs that they don't put prescription monitoring programs, they don't put methadone, so you might not know somebody's on methadone, whereas buprenorphine is usually on the prescription monitoring program, which is my best friend. It's how I do my detective work. But so I don't know, things to consider. Recent evidence suggests higher initial and maintenance doses generally safe when carefully titrated and monitored. So just be careful of that increased risk of QTC, prolongation, and torsades. That would be very bad. But overall, rates of overdose and serious arrhythmia have been shown to remain low in well-monitored settings. Okay, tramadol, talk about tramadol. I don't know. I don't think that, not a fan. So because I have had patients that become addicted, I think we didn't treat it like an opioid when it really is a weak opioid. So it is an opioid agonist that inhibits the reuptake of monoamines. So affects how the brain and nervous system really perceive pain. And then it gets metabolized in the liver into a more potent metabolite. It comes in various formulations. It's a controlled substance. Its potential for abuse is high. I have a friend, not a patient, but she would take her mini dachshund to different vets around the area for tramadol and opioids for pain and makeup stuff and hydrocodone, and well, then she got busted. But she didn't do that anymore. Anyway, so just to be careful, it's not a benign substance and there's serious side effects can occur, like seizures can lower your seizure threshold and cause serotonin syndrome. Anyone heard of Tapendal? Tapendadol? Yeah, this one was a new one for me too. This was earlier this year. I've seen all this stuff. And this is from the Louisiana State Police. A multi-agency investigation leads to seizures of more than 13,000 tapendalol pills. And I was like, what is this? They call it pandas on the streets, I guess. But it's similar to tramadol. It's 2 to 3 times more potent. I think it's called Nucenta, maybe its trade name. But it combines mu receptor agonism with noradrenaline reuptake inhibition. So it's a really strong analgesic effect with a synergistic action. And opioid antagonists like naloxone don't inhibit its efficacy, which is kind of scary. So they have seized lots and lots of tapendalol pills here in Louisiana. Look out for those pandas. All right, cannabis for chronic pain treatment. I don't know, I know each state is different. It's maybe an unpopular opinion, but I think cannabis is not medicine. And so I'm a family doctor and a member of the AAFP, and I disagree with them, but they said, that non-inhaled medical cannabis or cannabinoids may be considered for chronic pain that is not adequately controlled with standard care. Well, I don't agree with that, especially not if you have I don't agree with that if you have a substance use disorder, I guess, or active or history. But they found that based on moderate to high certainty evidence showed small improvements in pain levels, sleep quality, and physical functioning with non-inhaled cannabis or cannabinoids compared to placebo. The number needed to treat though was 10. For buprenorphine, the number needed to treat save a life is 2. So and that's just to achieve a greater than 1 centimeter reduction in pain on a 10 centimeter visual analog scale. So recommendation is specific to non-inhaled formulations based on studies in older adults with various pain conditions. So not the non-inhaled. And there are systematic reviews and meta-analyses that show that cannabis-based products that are higher in THC to CBD ratios can also result in small to moderate improvement in pain, chronic pain, especially for neuropathic pain. But you do get adverse effects, including dizziness, sedation, cognitive impairment, and nausea, higher rates of steady withdrawal due to these side effects in trials, high THC products, and what is out there now? Excuse me, this not the medicinal marijuana, but just marijuana is way more potent than it was in the 60s or 70s. This is not your grandma's weed. This is really strong, potent stuff that we are seeing now. So you get that risk of psychiatric and nervous system adverse effects is increased, and long-term safety data remain insufficient. I just this morning saw a news report that a pharmacy student was killed, 27, was killed. She was smoking cannabis with another pharmacy student, and that other student got really paranoid and shot and killed her. Or I don't know if it was, shot, but he killed her. And that's so tragic. They thought they were just smoking weed or doing whatever. It's not a benign substance, but apparently there's evidence for benefit in treating neuropathic pain. Okay, so the efficacy and safety profile varies by product formulation and route of administration. It's not regulated. Cannabis is not FDA approved for pain management in the United States. It's the only FDA approved cannabinoid is indicated for seizure disorders and may be considered adjuncts for chronic pain management when standard therapies are not adequate. Not for my patients, I will not recommend it, but benefits are generally small and must be weighed against the risk of adverse effects and the lack of long-term safety data. Oh, yes, yeah, Marinol, sorry. Yeah, I did forget, I gotta add that to this, Marinol. Has anybody heard of this Journavax? Yeah, so this is a new, apparently it's helpful in acute pain. It's a peripherally acting non-opioid analgesic that selectively inhibits the sodium voltage 1.8 sodium channels in peripheral nociceptors, and that inhibits pain signaling. And there have been clinical trials that have demonstrated its efficacy in acute pain, that's comparable to the hydrocodone with Tylenol, which is Lortab or Norcos. But the current studies that we have are limited to short durations of treatment, so it's only recommended for acute pain. There's further studies that will need to be conducted to see its long-term efficacy, safety, and addiction potential to be utilized in the management of chronic pain patients. So I don't know. I heard of this. I was skeptical, but it is out there. And very expensive apparently. And I don't think insurances are covering it. Okay. So if you do have to manage somebody on chronic opioids, I mean, it is what it is. My mother-in-law is a dental hygienist and has a really bad neck and has had surgeries, and she gets prescribed Norco from pain management by her doctor, and she will go and she'll give urine drug screens, and she's monitored. So frequently check the prescription drug monitoring program. I don't know how, I don't know, I've seen some very interesting things. I have seen polypharmacy, multiple providers. It's just like things are just crazy. And I don't know, people are still prescribing this patient stuff. Like, I don't know, it's nuts. But I check it frequently. And I encourage you all to, every time you do prescribe like buprenorphine or an opioid, you check a person's PMP too. You might be shocked at what you find. Anyway, but like I had said earlier, methadone dispensed at an OTP is not going to show up in the PDMP, and that is due to CFR 42. And medicinal marijuana was showing up on Louisiana's PMP up until January. And now it is not. And that's really upsetting to me. I'm trying to get it back, but I don't know how to do that. But regularly reevaluate your patient's opioid use. Ask your patients about the 4 A's: analgesia, activity, adverse effects, and apparent behaviors. Want people's quality of life to improve. That's the goal. And you might want to use toxicology testing for medical monitoring of adherence. If you got a point of care cup, you want to make sure your patient's taking what you're prescribing. I learned my lesson very well. When I was working in this litigation practice, prescribing this guy, his mom would bring him in, I don't know, he's in his 30s, Percocets, like 90 Percocets a month, 3 Percocets a day. He'd come in like clockwork, he'd give his urine, there's oxycodone in the urine, the point of care cup, it's normal, so I don't send it off for confirmatory testing because it's always normal. And then one day, he didn't show up after months and months and months. And come to find out, he had been diverting his Percocets, and he had overdosed and died. And yeah. But at least, I mean, it's really sad, but so it's not, you never know. Anyway, so exercise caution when escalating doses above 50 morphine milligram equivalents per day. And this is kind of showing what greater than 50 morphine milliequivalents per day will look like. There's limited benefit to going higher, and you can increase harm. But that's like 50 milligrams of hydrocodone, 12 milligrams of hydromorphone, 30 milligrams of oxycodone, and a fentanyl patch. It's like 12.5 micrograms per hour. Recommend or prescribe naloxone to reduce overdose risk. I used to carry Narcan with me. I don't have it with me today, but if you are going to taper opioids when their risks outweigh benefits, go slow, personalize the plan. Definitely want to address the anxiety that's going to come with that and their fears that are going to come with that, and just encourage the patient through the process that they can do it. And the CDC has that their guidelines on that. So, and working with the elderly, especially start low and go slow, what is what I was always taught in school. But I was kind of shocked to learn that that is how marijuana dispensaries are telling our kids how to use marijuana. Start low and go slow, because I know it's so potent. Yeah, I thought that was interesting. But anyway, monitor these folks for side effects, adjust for renal dysfunction or hepatic impairment, and reduce polypharmacy by incorporating non-medication approaches. So fear drives chronic pain. I don't want to be in pain. The anticipation of being in pain, the story that we tell ourselves, like it's so awful, I can't be treated. It's really that fear and those feelings that we get with the pain that's really worse than the pain itself. So there's fear reduction techniques that can be used to help manage reducing pain. And here, this is just kind of showing that the vicious cycle, kind of like addiction. This is the cycle of uncontrolled pain and fear. You fear the pain, you avoid doing things that might help the pain get better, like being mobile. So you're sedentary, then you get decreased mobility, and now you can't work anymore. You get that altered functional status, diminished efficacy, but now you're sedentary and isolating. You don't go out into the real world, and it just goes on and on and on. So these are treatments to help break that cycle. These are multidisciplinary treatments for pain and also for substance use disorder. So I've seen a lot of these used concurrently. CBT, cognitive-based behavioral therapy. I mean, I think everyone should have a great therapist or access to a therapist, but and that's because a lot of my patients have history of trauma. So I try to practice trauma-informed care, but cognitive-based therapy, behavioral therapy can be helpful to treat pain and substance use disorders. Acceptance and commitments therapy, somatic experiencing pain reprocessing therapies. These are not things that I'm trained in, but there is evidence that these are helpful. Exercise, just being mobile. We take our patients. I'm now working at a new residential treatment facility, and we try to get our patients up and moving. We'll take them on walks. It's good for releasing those natural endogenous opioids, and just getting people active. Mindfulness practice can help reduce anxiety, can also help reduce depression, can help reduce many things, and can help reduce pain. My therapist always tells me to journal, and so I guess expressive writing has been shown to be helpful. Nutrition, like I have a colleague, she's very big into the nutritional aspects of, having probiotics, you want to have good gut biome, like anti-inflammatories, like turmeric. She's very into the nutritional part of being healthy, and That's how she approaches both pain and treating substance use disorders. Hypnotherapy, EMDR, eye movement desensitization. Not everyone's trained in that, but it can be very helpful in reducing processing trauma. Motivational interviewing, mutual help groups, like there's 12-step recovery, not just, well, there's 12-step recovery for everything. And there's 12-step recovery for chronic pain, like Alcoholics Anonymous, this 12-step recovery, NA. There's a 12-step group for everything. And then COVID put it all online too. So people can really get fellowship and find the camaraderie and support that they need a lot easier now all around the world. Yoga is a treatment for both, so encourage people to do yoga, acupuncture, and again, this fear reduction. So breathe, move, feel, heal. I might be able to do like that one where she's just laying flat on her back, but that's total relaxation. And these are evidence-based treatments for both pain and substance use disorder. So you break the cycle. And exercise, you get increased mobility, improved function. And this is like the miracle that I get to see working in a residential treatment facility when someone comes in and there's emotional pain and they're going through withdrawal and they're a disaster, but then you get them, stabilized and you get them exercising and up and at it, and they just look great. It improves so quickly. It's awesome to watch. Okay, so my key takeaways. Addiction medicine is not pain management. At least here in my state, I get a lot of referrals from hematologists and oncologists to help manage their pain of their sickle cell patients because they don't want to prescribe buprenorphine. But if your patient uses, if they don't meet the DSM-5 criteria for having an opioid use disorder, they don't belong in an addiction medicine clinic. I think don't have fear prescribing buprenorphine. It is safe and can be really helpful. So, okay, you got to balance the pain relief and addiction risk. It does require that patient-centered multidisciplinary approach. That's kind of what I learned as a family medicine doctor, and that I can take to, I use in my addiction medicine practice. Prioritize non-opioid therapies, carefully prescribe opioids if you're going to do it, and then of course ongoing risk mitigation is important. Okay. Sometimes I think pain has to be treated before you can address the substance use disorder, especially this depends on the level of care, but especially in residential treatment or in detox, because if you don't address the person's pain first, they will go ballistic and they can't concentrate on the other parts of recovery that are really important to them. So emphasis should be put on treating someone's pain. Okay, since I was given a little bit extra time, which is why I try to go really slow. And I try to I came up with some vignettes, and these are actually patients that I have had in the past. So, Miss Judy, that was not her name, but she was a 60-year-old female nurse. She came to residential treatment for a severe alcohol use disorder. And on admission, she told me she had a past medical history of scleroderma, rheumatoid arthritis, and lupus. And she had been following with pain management for many years. Well, pain management had been initially prescribing her large doses of opioids, like Emma's Con. And when she started running out of her medication early, due to taking extra since her pain wasn't adequately controlled, they said, no more opioids for you. And they told her to try medicinal marijuana. Well, that really was not sufficient for controlling her pain. So she stopped using the medicinal marijuana and started to use alcohol to cope with the pain. And now her drinking was out of control. She told me on average, she rated her daily pain as an 8 out of 10 every day. And it was affecting her life. She was not able to work, not able to enjoy her grandchildren. So, the group has gotten bigger. But anyway, might be some options to treat this lovely lady?
Hi there, I'm enjoying your talk. I have a question. In terms of 8 out of 10, that's her subjective symptoms.
Right.
What physiological concomitants you have to actually show that there is a sympathetic response? That's question number one. Question number two is, with this whole approach, how much, I don't see anywhere there's anything for religion. And just seeing a whole religion thing for this. And finally, as my friend who I work with, who's a psychiatrist, he's been doing things from Prozac since the 90s. He tested it. He's been doing for years ketamine. And his thought is that ketamine can allow one to go to a place faster, to then go through these stages in much faster way. But his experience is, if you've been damaged for over 15 years, it's a problem. If you're damaged less than 15 years, that seems to be a cutoff point. What are your thoughts about that?
So yes, psychedelic research is definitely increasing. There's a lot of interest in it. I have never, as an addictionologist, taken care of anyone that's come in with a primary psilocybin use disorder. So we're trying to actually get involved with that, exploring, doing research at Tulane. I don't know how I feel about it. Probably would not support it, but that's also why I need to do the research to know that, so I can know more. I can make an informed decision. The religion aspect, yes, didn't talk about that, but 12-step recovery does include spirituality. But I might need to look into that. And I'm sorry that I didn't understand the first part of your first question.
The-
Anyway, but
Okay, well, yeah. What, excuse me?
Your first question?
yeah, what was,
Well, that's right, measuring it, because basically there is a difference between feelings and emotions.
yes,
Emotions are a physiological concomitant. You can see things. Now, what's interesting psychologically is that emotions can actually be seen, and and they're actually easier to treat. The problem is feelings. Feelings is a more long-term thing, a more subjective thing. The whole point about it, where I see, like, for example, in this lady, where they're saying scleroderma, rheumatoid arthritis, lupus, this is all this kind of diffuse sort of thing where people, you're given that diagnosis and you have this autoimmune thing going, and then people give you this and then treat you this, but you may have like a little fasciitis. And the fasciitis might actually respond to something else. And then we kind of go more into this feelings thing. It's really hard to get around.
right. I gotcha. Yeah. And I don't know. This is what you reported, and I understand it's very subjective.
Okay, here, let me.
I got, now I have two.
Give them two.
So, to answer your question of what would be a good treatment regimen for this, can I ask a couple questions about where we stand?
Sure.
So is she actively on opioid therapy at the moment?
No, so,
So the opioid therapy has been stopped?
yes, so I should have been clear. This was a history and physical in a residential treatment facility.
Got it. So she hasn't taken any recently. Naltrexone could show use in both the opioid use disorder and the alcohol use disorder. Anecdotally, I found it better orally for alcohol use than I found it in Vivitrol for alcohol use. And as far as the pain goes, where is her pain and what's the nature of her pain right now?
Yeah, pain is everywhere. Hands, just generalized
Okay, so
Joints.
mostly
joint.
or
Yeah,
mostly joints. I check her liver enzymes first with the alcohol use disorder, but potentially a combination of Advil dual action, the 500 milligram acetaminophen with 225 ibuprofen every 4 hours as needed, and starting something like duloxetine in a patient like this could be useful.
yeah. I would definitely, if she wasn't on duloxetine, I'd probably definitely put her on that. What?
One, that's, I'm the token rheumatologist in the room. And first question I would ask is who gave them the diagnosis of scleroderma, rheumatoid arthritis, and lupus? Those three together, chances are somebody in primary care did labs and they've diagnosed her just on the basis of an abnormal blood test rather than getting a good history, good physical exam. We do not use opiates in rheumatoid arthritis as a general treatment because they have no anti-disease modifying activity. So I think that says to me, one other thing I will make a comment, and this is my personal opinion after years. I am in an area in the Southern Appalachian Mountains. We are within 2 hours drive of Hazard and Harlan, Kentucky. Need I say more? There are areas, that's an area where there are like 500 or 1,000 opiate pills given per person per year. I am of the feeling, and I think the more I see, the more I agree, and I've talked to my colleagues when I've been on government affairs and everything else, that a lot of the opiate problem and the pain medicine problem is directly related to our federal government because we were given this, we have this now a fifth vital sign of pain. And when you do MIPS and MACRA, you're told that you need, if this patient isn't at pain level of 0, what are you doing to fix it? And my colleagues in rheumatology said, we have a patient with rheumatoid arthritis who has a pain level of 3 or 4. Guess what? They're doing pretty good. And so what happens is we have primary care people who are not well trained in how to manage pain and how to look at pain. They get this thing from their organization saying, hey, you need to be doing a better job of pain. So what do? They try Advil, they try Tylenol. When that doesn't work, then they go to the opiates. And so they are helping to make addiction medicine, problem. My brother is an internist who is also boarded in addiction medicine. And so I give you and he both a lot of credit for doing this because this is a tough situation we're in. But I honestly think that a large portion of this is due to the federal government who pushes on us. How are you going to fix a problem that may not need fixing? That's my thought.
100% agree. But she's just coming in for residential treatment, 60 to 90-day program. Primary complaint was alcohol use disorder. And so I, had to treat her pain first. I did put her on low dose naltrexone, which if she was getting the alcohol use disorder dosage, that would be like 50 milligrams. And Vivitrol is designed to give 50 milligrams. But I just titrated her up to 4.5 milligrams. And I don't know, maybe it was placebo effect, but she did really great. She got out of residential treatment and she went to intensive outpatient programming and she completed that. And her pain was now a 3 out of 4. It was manageable with ibuprofen. And, she was able to do the things that were important for her in her recovery, like enjoying time with her family and her grandkids and doing all the fun things that she couldn't do before. So it worked. Her husband came in and gave me a big hug, and that was really nice. Okay, real quick. Nope, no, real quick. But I didn't talk about kratom. I don't know, in some of your all states, you might here your people have patients that had a history of opioid use disorder. Kratom was legal, so they started using it. 7-hydroxy, metragenine. I don't know. I was just in Kentucky. My father passed away, so I had to go back up and settle some of his affairs, and Kratom's still legal there. So it was just mind blowing to me because I've definitely had taken care of patients with it, including this veteran who had a history of alcohol use disorder. He was being prescribed Lortabs by the VA for his low back pain, but that wasn't enough for him. So he started buying like cases and cases of this liquid kratom off of the internet, which is starting to get really expensive for him. And when he tried to cut down, he had experienced opioid withdrawal. So this is in residential treatment. This is an H&P, and you're right, I should have been more specific. But I put him on buprenorphine, and he did divided the dose, and he did well. So that's how I've been treating kratom. And I will say, when I use buprenorphine, it is lower doses than the full dose. So, okay, this is my email address. Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.